After his graduation from Basel in the year 1980, he has honed his skills under great luminaries of orthopedics and sports surgery, like Professor Werner Müller, Professor Christian Gerber, Professor Freddie Fu, Professor J.P. Warner, and Professor Chris Harner, and many more. He is a distinguished member of ISICOS, ESCA, CCOT, German and Swiss Society of Shoulder and Elbow Surgery. He has to his credit many awards from various academic bodies across the globe, like the ANA, Malaysian, Argentine, Indian, and German arthroscopy societies. He is on the editorial board of Arthroscopy Journal, Journal of Shoulder and Elbow Surgery, AJSM, CASTA, and many more. He has published numerous articles in various index journals. To his credit, till 2020 were 484 articles. He has edited around 37 books. And the 41 years of experience, Professor Aimov is going to sum up and present his experience to us now. Welcome to you, Professor Aimov. Over to you.
Thank you very much. I'm so honored, and yeah, what shall I say? I'm just nice that I can be here with you. And I know 40 years of my life spent with orthopedic surgery. Now I try to bring you some new insights about the AC joint. So I try to bring you the slides. Okay, I hope you can see it. Can you see it now?
Yes, Professor, we can see it.
Wonderful. So that's Munich, and you see in the back of Munich, the Alps, the German, Bavarian, and Austrian Alps. We have still a little bit of snow because this winter was quite hard, but a lot of old buildings are in the middle of the town of Munich. So AC joint, where are we today? I will tell you a little bit of biomechanics in the back. The new ISOCOS classification, my experience arthroscopically since 2003 when I started to do it arthroscopically. These are my disclosures with Arthrex, outer surface, and MEDI. And we just start with a case. You see now 23-year-old female sports science student. She had an acute grade 4 AC joint dislocation while snowboarding, and you see the translation of the clavicle posteriorly, a little bit higher, but mainly posteriorly, so a horizontal instability. She got some surgery somewhere, not in my hospital, with 2 tightrope system. It's not so bad. You see the 2 tunnels here, 2 plates here underneath the coracoid. On the first view, it's not so bad. But then 3 months later, she fell down on a stair, and now it dislocated again. What shall we do now? You see now, it's dislocated in the horizontal plane, but in the vertical plane, the plates are still here, so something must happen. So we did a CT scan. The clavicle tunnels are not so bad. 2 tunnels, maybe a little bit too close, it's not anatomic. But on the coracoid side, you see now the problem. 2 tunnels are in the same space, confluating, too big now. That's why these pieces, these metal pieces, these dog bones went into the bone, and that's why it was not stable. So what shall we do next? So it's a recurrent instability, it's chronic. What shall we do now? Now we go back a little bit to anatomy. You see the lateral clavicle, the AC joint capsule, the fascia around, 2 ligaments, 2 distinct ligaments, the conoid, it's more for the vertical stability, and trapezium for the horizontal stability. So we have dynamic stabilizers and static stabilizers. Static means these 2 ligaments are for static, and dynamic are mainly the muscles, delta muscle, trapezium muscle. So when we look for the stability, here, when we transect the capsule, we have different parts of the capsule. We need them for horizontal and rotational stability. It's also some rotation in this joint. That's why it's so difficult to keep it. When you look here to the rotation, you see how much it's possible. That's why it's so difficult to stabilize. And when you look to the insertion side on the coracoid, here's for trapezium, here's the conoidium. At the base, the coracoid is quite big. It's about 9 millimeter. But here at the edge, where trapezium is, it's only between 5 and 7, so it's quite small. So when you drill 2 tunnels, be careful, otherwise the coracoid will break. And then these are really important landmarks for these 2 ligaments, 2.5 for the conoidium, 4.5 for the trapezium. So you can measure from the AC joint to the medial side where it should be, and this is published in HSM. To find the correct insertion site, sometimes it's difficult. The conditions are sometimes difficult. We did a systematic review. It's in the BMC published. There is not really a consensus on the gold standard. So the inter-observer reliability, especially for the vertical instability, is quite low. And that's why maybe we have so bad results. So keep an eye on the horizontal stability. That's much more important than anything else. So finding the correct diagnosis, in this case, it's easy. It's Rockwood 5, 20-year-old male. That's quite easy. You see it, you compare left to right, it's quite easy. But here, this is not easy. When you look at it, and when you look closer now, on the AP view, it's almost normal if you compare. But here, when you look from a different angle, then you see that's horizontal instability. So you need more specific imaging technique to really understand it. And then the second biggest problem is the scapular dyskinesia. The function of the scapulothoracic joint is the key of the shoulder. And when we studied this in 34 patients with chronic AC joint dislocation, about 70% had a dyskinesia. So always look from the backside of the patient. Look from the backside, how he's moving his shoulder. And then you understand that how important the clavicle, how important the AC joint is. So when you have it, start first looking from the backside to understand what is it. Is it a grade 3 or a grade 4? And the Rockwood grade 3 is more difficult to understand because you don't see it from the first view on the X-ray. These patients, they don't need always surgery. If they have pain and a dyskinesia, and the cross-body adduction view, Basmania or Alexander view, can show it quite nicely. And if there's an overriding of the distal clavicle, then that's what we call type 3B. And there's a need for surgery. It's no overriding. You can continue non-operative surgery. And that's the so-called ISOCOS classification now, published in Arthroscopy 2014. And there is the shoulder committee of ISOCOS published this. Now, how we do it, this is my current arthroscopic technique, and it goes quite fast through. We have 2 portals, one anterior with a passport cannula, a second portal under superior through the supraspinatus, as you can see here, where we have the camera now, and then we look from the side, from the lateral side, underneath the coracoid. We have 2 small incisions, one incision just above the AC joint, one a little more medial. We pull and we drill through the acromion, the clavicle, just for the horizontal stability, a cross link, but we do not fix the knot, just a perpendicular, just a fixation for some time before we start the drilling for the CC ligaments. These are new drills, 2.4 cannulated, so it's quite easy, small drills, and then we can place the dog bone underneath and above the clavicle. And this is the final view, and then we fix the cerclage for the AC joint. So let's just show. We go now a little bit more slowly through everything. Again, you need 2 portals to prepare here the undersurface of the coracoid, especially the base of the coracoid with an electrothermal device. And then we drill, because now it's easy. Now the clavicle is a little bit higher, so it makes it easier to make 2 drills two holes with a 2.4 drill guide, where we can use a fiber tape going through, and here's a lasso together with a fiber tape. We just put this down, keep this with a clamp like here, and then we have everything stable. We can control it with an X-ray control until we are sure that it's stable and the correct position before we start now drilling the coracoclavicle part. And then finally, these are two types, one dog bone underneath, and you look with your camera underneath the coracoid. You can place the button quite nicely here at the base. That's for the conoid. Conoid is important for both for horizontal and vertical stability. Let's see, yes. Now you pull the fiber tapes, and the second dog bone is above the clavicle. And then, because we already have the reduction, you can just use the normal knots. And when we have a chronic system, we use the same system. Here I had two systems now, but I need, in addition, a gracilis tendon, like here, the white here, going around the coracoid, around the clavicle, because we need some soft tissue, we need some tissue for healing in the chronic case. So we can combine this technique with the gracilis tendon. You see the schematic drawing here. You see here the two systems here, two tight ropes. And finally, the gracilis is going together with one of the system underneath the coracoid. And now we have one system here for the fixation mainly, and the second is the gracilis going through the second tunnel. The tunnel for the gracilis is a 4 millimeter tunnel, so the gracilis has enough space to go through. Now you see the final laparoscopic part here. On the right side, you see the gracilis tendon now coming from the lateral side through the coracoid. So we have a tendon bone-to-bone healing, bone-to-tendon healing, final view. Sorry, that was too fast. That's a final view now. You also can use a temporary fixation with a key wire. In chronic cases, that's quite helpful because it keeps you the stability as long as you do everything laparoscopically. Just use a key wire, and then you can do everything like you would do. The additional cerclage for the AC joint has a lot of biomechanical advantage for horizontal and rotational stability. This is a study we did also published in HSM together with Gus Masoka. As you see now, when we fix it with AC joint, we have really an additional benefit. Suture pulley system demonstrated excellent results. Two bundle reconstruction, that's a 5-year result. Follow-up for 5 years, 96%, we're very satisfied. Return to sports, return to activity is almost normal, especially in overhead or contact sports observed. So no significant change. So I can just tell you that this technique is working, and we have in the patients quite good results. Also biomechanically, quite good results. We did several studies and published this in HSM several times. KST also biomechanical evaluation, different holes. So this technique is really proven. So finally, our case from the beginning, what I did again the same technique now, but I drilled more medial, more at the base of the coracoid because the bone is still intact. One big suture button here, a new tunnel, fixed it, and you see now she's doing the sports again. Sometimes if the bone is broken or you think the hole is too big, you can use a lateral clavicle plate, as I did here. In this case, there's a small curved clavicle plate, and the button just flips into one of the hole, and then you have more pressure against the bone. You are on the safe side, so it doesn't matter. You have enough pressure. You can use this. And underneath, also different possibilities. You can use different plates, bigger plates, because we are coming from the side. You don't need a big hole for a bigger plate. Coming from the side, place it correctly. You can use two dog bone and fiber tapes. And this is the final X-ray. Now in this case, you see when you have big holes here, maybe sometimes it's better to use a small plate, lateral clavicle plate. The same technique for lateral clavicle fracture. because it's more stable than just the blade alone if you have the compression to the coracoid. These are the take-home message. You understand that the AC joint is very important for the 3D motion of the scapula. Scapulothoracic motion is important. There's no gold standard still, but I can tell you now after 20 years now that we have really good results. Anatomic techniques is most favored technique. Internal bracing is wonderful. And we use a biological graft. Otherwise, our technique, the tapes will break sometimes. So thank you very much. And I'm open for any kind of questions.
Thank you, Professor Ayama, for your eloquent lecture on this topic of, very uncertain results, because there are new and newer techniques that are coming up to, really stabilize this joint, which is both horizontal as well as rotationally unstable. I would ask Subra and other members in the panel if they have any questions for Professor Ayama.
Hi, Professor Andreas Ayama. Hi, this is Dr. Subramanian.
Hello.
It was a very nice lecture. I think you covered everything. I have a couple of questions for you. One is, what is the threshold for doing ACJ fixation on top of CC fixation? When do you decide on to go for acromioclavicular joint fixation also on top of doing corpoclavicular fixation? That's number one. And then the plate that you were showing, was it plate going towards acromion also? That is the second question.
Yeah, this is just a normal plate for the lateral clavicle, but you have seen it has a special curvature, so it makes it easy. You can use additional screws for when we have a broken clavicle. There are smaller screws, self-locking screws. So this plate is wonderful for lateral clavicle fractures, but we always have revision cases, and sometimes the bone is too weak. So that's why we can use a plate like that. And then you can use the bracing through the coracoid, because then you can reduce the stress on the AC joint itself. You don't have to go to the acromion. The acromion can, the AC joint itself can be still open. And that's why it may help healing of the lateral, especially small fractures, small pieces of the lateral clavicle may be so difficult to keep this. So that's just another technique, just a solution. And the first question, in the beginning, when I started doing arthroscopically, I had to use some suture anchors in the coracoid. I used sutures going through clavicle. I said, okay, that's enough. I do it. And the results were not so bad. But then we did this biomechanical stuff, and we could understand that it's important to give them more horizontal stability. That's why we added this bracing for the AC joint in addition to CC. But CC is the most important part.
Dr. Anu, you have any questions? Dr. Mallikarjun, you have any questions for Professor Ayama?
We have some audience question. If you can look into it, one of them is asking what is a post-op rehab protocol after the surgery.
Okay. Professor Ayama, what is your rehab protocol?
Yes, you know, this technique is not very painful. It's mainly arthroscopical, and we do not open some joints. So these people, they don't have a lot of pain. This is the biggest problem we have. So we have to keep them a little bit. I give them a sling just for comfort for about 3 weeks. They shouldn't do external rotation, overhead activities like that for the first 3-4 weeks. These people, they are sports athletes, they want to do everything. And because they say, they stand in front of the mirror and they say, oh, it's nice, I can do everything, but they shouldn't. We need some time for healing. So anyway, it's a bracing, it's stable, no pain, but keep them calm. They shouldn't do too much for the first 3-4 weeks.
Professor, I have a question for you. I have seen you doing the single dog button, and also I have seen you doing double buttons, 2 tunnels in the clavicle, 2 tunnels in the coracoid. Now, understanding the anatomy of the space that you come from and our anatomy in our country, there will be a huge difference to take 2 tunnels in the coracoid. And you rightly put the most complicated problem in your ACG surgery as the first slide. If such a thing happens when you're trying to do this dog button kind of a thing, what is the bailout for that? That is number one. Number two, currently we are addressing the rotational problem that is influencing the outcome of ACG surgeries. I know you are working along with Dr. Mazoka and the team and all on a lot of papers. We go through that. Currently, your understanding is the posterior capsule of the AC joint has got more to do with the AC joint instabilities that you are looking at. So your current thoughts as well as how to bail out of the situation.
Yeah, rotational stability is so important. That's why now we understand more about the different part of the capsule of the AC joint itself. So the posterior part, superior part are really important. And that's why when you make a small incision, you have your brace, box brace or cross-like braces, and then we use the capsule and cover everything together. So we have a secure fixation of the AC joint, but it's still not stiff. There's still some little motion possible, because when you move your arm, you know that, then you have always a little bit of rotation. So that's important. And the second question is about revision cases. In almost all cases, I had the possibility to place my tunnel more posterior at the base of the coracoid, because when you really have drilled posteriorly, the coracoid will not break. The coracoid breaks always in the middle part, where, you know, when the coracoid is like this, it will break here. So when you go here at the back, rear and the back, there's almost all the time enough bone. If not, you still can use a blade, and I have this experience to use a blade, a bigger blade going from the clavicle to the acromion, but that's not anatomy. I don't use a hook blade anymore because there are so much forces on the hook itself that the hook will go sometimes through the acromion. It's just a question of time. We need something really fixation to the base of the coracoid. And in the beginning, in 2002, 3, and 4, I used just a corkscrew at the base of the coracoid in the supraspinatus fossa. That's another possibility. It's like in the tradition of the Bosworth screw, where we put our screws just directly at the base of the coracoid. Another possibility, but Bosworth screw doesn't work because it's stiff, doesn't allow your rotation. So these screws will break and will loosen anyway.
Subra, you got any questions? Dr. Mallikarjun, if you got any questions for Professor?
So we have some questions from the audience.
Yes.
They want to know about the arthroscopic coracoid exposure. That's one question, and some other persons want a more description on the dog bone procedure. So do we have time to take this?
Yeah. Yes, we start the procedure with a normal arthroscopy of the shoulder, going the normal posterior portal, and then we switch to the lateral side. So you need at the end 2 portals on the lateral side, superolateral and posterolateral, because you must have the possibility to look underneath the coracoid, and you need 2 portals because you need your scope and the electrothermal device that you can clean everything. You are just in the line of the subscap. So it's the same way when you do a subscap repair. I always switch my scope to a lateral side to see my subscap in line. So it's the same way to see the coracoid. And between subscap and coracoid, it's only a small bursa. It's easy to open it and to go underneath. And there are no vessels, no nerves around. Coracoid is free. You can just see it nicely and you can prepare it. And maybe in the beginning you feel it, but then you see how big it is, how big medial it is. And the new drill guides, they have a stop so we can hook it in medially, and then you can measure the distance, 9-10 millimeters, before you drill through the coracoid. And the second question was about the system. You can use any kind of tapes. I use fiber tapes because they're really strong. Two types correctly. And you can use any kind of blade, because since we have these small drills, 2.4, it's easier, and you don't have to drill a big holes. In the beginning, in really beginning, I had to drill 4 and 5 millimeters, and that's too dangerous. That's why we do this. We do this not anymore. That's maybe a reason for breakage of the coil grid.
Professor, I have one question here for you. We have all graduated from being open procedure surgeons to being arthroscopy surgeons. In the current scenario, what is the role for open procedures in AC joint surgeries? And how do you address deltotrapezial fascia in arthroscopic procedures? 2 questions.
Yeah. So the trapezium, the fascia is quite important. That's why we open now the AC joint itself, a small incision, and at the end we close the AC joint after bracing with the fascia itself, because I agree completely, the fascia is very important. So at the end, just close it. That's open. But everything else between coracoid and clavicle, that's arthroscopy. And I never open an AC joint anymore, because it's much easier. I tell you, it's much easier if you go in with your arthroscopy underneath. When you do it open, you know, when I was a resident, we went in like this, and the surgeon said, "Oh, here's the ligament. I see it. I can take it and fix it." But it didn't work. It didn't work really, because it's a small ligament. It doesn't work. So I really can recommend, try it arthroscopically. It's not difficult.
Subra, you have any questions for Professor?
I think there are a few questions in the chat box.
Yeah.
I want to ask 1 or 2 in that at least, so that the audience will be happy.
Yeah.
One of them, will you add a K-wire always? When will you remove the wire? I think you probably won't add K-wire, would you? Professor Emma?
I didn't understand it, sorry.
K-wire for the fixation? Kirschner wire?
Do you stabilize the AC joint with the Kirschner wire?
Yes, correct. Especially in chronic cases where it's more difficult to reduce it. It makes your life easier. When you reduce it, look under your fluoroscopic device, bring your key wire from the acromion to the clavicle. It makes it much easier, because then it's stable and you can drill everything, and then at the end you take it out, and that's it.
Now, how do you deal with a broken coracoid? So another question.
Yes, just go more posterior at the base of the coracoid. Then there's always enough bone, because the bone is quite large at this insertion to the scapula. Otherwise, you also can use a screw, corkscrew or something like that, and fix it to the bone.
See, there's a question about how much tightness would you apply when tightening graft? Would you just put a finger pressure, or would you use?
No, just reduce it and keep it in this position. No more tightness, no.
Professor, when is the return to sport for an elite athlete or a recreational athlete? Is there a difference between both, or they return at the same time?
Yeah, the main time we need is healing. Healing is 6 weeks. And then after 6 weeks, they can start the training. Contact after 3 months, like ice hockey or something like that. After 3 months, overhead, again 3 months. But it's the same for everybody. But after 6 weeks, they can start the training.
I understand you have got one more talk to give. That is what was told to me.
No. We're going with the case presentation, Dr. Rajkumar. You and Dr. Subramanian can present some cases for discussion.
Okay. If any more questions are not there for Professor Imhoff, I'll ask Subramaniam to present his case, and then Professor can moderate, and we'll take it forward. Dr. Mallikarjun also can moderate.
I just have only one case to show. We'll just fix it.
Please share your screens.
Are you able to see the screen?
Yes.
So let's see whether I can put the play mode.
Before Subra can start, I would like to thank Professor Aima for his wonderful lecture and the time given for OASIS Con. And we really appreciate your presence in this August meeting, sir. Thank you.
I have this case, who I came across like a few months ago. This young lad who is only 19 to 20, his age was, who came with this fall and had a dislocation. It was operated somewhere else. So, what will be your next line of action on seeing this X-ray? One of the panel can answer. Maybe Professor Aima, what will be your management for this patient who is presenting with this X-ray? Yes.
Okay, thank you.
An acute scenario.
But you see, there is a distance between clavicle and acromion, so it's a instability, but we need more information about in which kind this is unstable, is horizontal or in the vertical plane. So we need at least a second or third view from the lateral and the axial view. And if it's acute, it's okay. Otherwise, if it's chronic, think about a CT scan or MRI to see additional problems around a AC joint.
Just want to make sure any other panel members, any disagreement with going for further investigation? Or we all just go manage with X-ray, or do you want to do a CT scan, MRI scan, anything?
I think we need.
We have an audience question. What is the specific X-ray you look for in the AC joint? Can you elaborate on that?
Anyway, I did not have this patient at the outset. It was managed elsewhere. He was had a K-wave fixation done. He did not have a CT scan or MRI scan at that stage. What is your opinion on this fixation? What is the chance of it getting through without any problem?
Yeah, the problem will be the healing. Why and how should this heal? If you use a precise preparation, you use the fascia, the piston fascia, that will be okay. But anyway, you cannot expect that the CC ligaments will heal because they are destroyed when they have a dislocation like that. So they will have a little bit of translation superiorly when you take out the key wires, and the key wires must be taken out after 6 weeks. Otherwise, they go through the skin. I miss something between the coracoid and the clavicle.
Well, probably it was a type 5 dislocation. We did not have a scan or MRI to start with. For a type 3, you might probably do a K-wire. For a type 5, what will be the line of management would you think about? Would you do a button fixation?
Yes.
That's what you would do, isn't it?
Yeah, correct.
So we had a K-wire removal done about 2 months later. I think the X-ray doesn't look that bad. As you can see in this, it looks reasonably reduced. And looking at the literature for the audience is comparing tightrope and K-wire fixation. Tightrope is actually does well in terms of failure rate, where the studies, multiple studies have shown that the K-wire will have about 15 to 20% failure rate. That's what the roughly indicator percentage of failures in K-wire fixation, only K-wire fixation. If you do a tightrope or any button kind of fixation, the failure rate is not 0, still about 9 to 10%. That's what it is. So in first month itself, after taking the K-wire out, this patient had started having pain. Now he is coming to me with this redislocation again. Just want to know your thoughts about it. What will be the plan of management at this scenario? Now he is now about 7 months down the line since he had the K-wire removal, and is again his same pain and not able to do his shoulder activity comfortably. He is only 20 years old chap, so he wants to have a perfectly normal shoulder. That's what his expectation is. So what will be the line of thinking, and what would you like to do? This is a chronic neglected ACJ dislocation currently.
Professor, your thoughts on that? Professor Aimov.
There was no really healing. That's why it dislocated again. You need some soft tissue. You need some biological answer that they can heal AC and CC. First, you can bring back the clavicle to the acromion, that's okay, but you need an additional fixation between coracoid and clavicle. You can use a figure of 8 cerclage between clavicle and coracoid, but also some refixation, bracing of the AC joint itself to give him back the stability.
Rajkumar, what is your view?
Professor, I have a question for both Subramaniam and Professor Imhoff. You said cerclage. Cerclage will be in the form of a fiber tape or some kind of a suture, or you want to use a graft so that either semi-T or gracilis to augment your repair.
Yeah, we need some augmentation with some sutures, strong sutures or bands. It's maybe better because it doesn't cut through. And then second, you need some biological tendon, gracilis, semitendinous, something like that. Otherwise, it will not heal. It will cut through again. It will dislocate again. And you can use just the gracilis because gracilis is about 28 centimeters long. You can use it for the coracoid, clavicle, but also between clavicle and acromions. You can use it for both. It's long enough. But for the first 6 weeks or 10 weeks, you need some additional bracing. The graft itself is not strong enough.
The problem with this patient was, I usually try to manipulate clinical and see whether you are able to reduce it.